We've already formed a quorum, so please invite the guests to come in.
請食晏可以請食晏，你歡迎我哋去隔離食晏，我請，唔係去 Grand Hyatt 都，但係我 book 地方係嘛？但係咁啊，如果完咗，點知完唔完話，跟早上完咗佢啦。啊
This is all public?
Oh, no worry. Nothing that we talk is not public.
Sunshine conversations.
早晨，早晨。
負責呢個章節嘅委員。
Okay. À, 歡迎高局長阿 Paul。
Welcome, Secretary Paul, and the other guests. I won't read out your names one by one. We're still on Chapter 4, Audit Report number 59, so we're to continue with our public hearing. Before we start the third session, I have to say that we completed the second session, and Mr. Leung is responsible for this session, and he'll ask questions first. But before that, I'd like to ask the Secretary to explain the two salient requirements in paragraph 2.10. The Secretary mentioned that after 1997, the grants would be automatically renewed. I'd like to refer the Secretary to Table 2. Note 1. Footnote, Note 1. Now please read that paragraph. It's very clear.
Say all leases granted which did not contain a right of renewal and would expire before 30th of June 1997, except short-term tenancies and leases for special purposes, must be extended for a period expiring not later than 30th June 2047. Special purposes lease, including private treaty grant for hospital use, were extended individually as appropriate. 嗱，喺呢度寫咗度咧，就
Well, the meaning is not that the grants would be automatically renewed. So, Secretary, why you said that on that day? Sorry, the speaker is not coming through. Well, I've read out the note. I cannot teach him how to translate that. I'd like the Secretary to explain why last time he explained that it would be automatic renewal. But here in the report, this is very clear. Would you please explain? Thank you, Mr. Chairman. I think I agree with you. Well, in the process, there have to be some considerations, and it won't be automatic renewal. Well, at that time, I based my explanation on a paper received by the hospital authority. Well, which paper? Well, the document issued on the 23rd of February 1990. Do we have a copy of that paper? Would you please refer us to that paper? Is it GN 594/GN3? The paper submitted to us yesterday. is annexed to our letter dated the 7th of December. Well, can you do this? Would you please copy that to us? Is that included in your papers yesterday? Which page? Well, Chairman, it's Annex C1. Would you please refer to Gen 59? Gen 59 4 / Gen 3. Annex C. Secretary, please. The paper was actually a letter issued on the 23rd of February 1990. It's a memorandum. Paragraph 2. It's Annex C1. Annex C1. Well, Secretary, in paragraph 2, it says that
document. That is, the lease will be extended on existing condition.
Well, my understanding is that after the Hospital Services Department had read this sentence, it did not ask for additional conditions to be added. Bernadette, would you please give us your expert opinion? Does this mean automatic renewal? We must clearly understand this incident. You are the land authority. Mr. Chairman, the paper tabled today does not only carry that sentence read out by the Secretary.
Amended, where there appears to be serious defects in the existing lease. 咁主席，我記得我上次喺呢度咧都有提過，其實的確當時。
Mr. Chairman, indeed, for the sake of the deeds signed before 1997, most of the deeds would be renewed automatically. But for PTGs, we have to examine them on their individual merits. On each case, we consulted bureaus and departments and circulated papers to them. As the Secretary said, normally we'll follow the general contractual spirit and renew the grants on the original conditions. But if it was considered that additional provisions should be added, we could consider that. So last time, the Secretary's reply was to reflect that situation. So within the administration, the Bureau and Department concerned made that decision. So the two salient points need not be added, right? And just now, the Director of Lands read out another provision. That means there's on the one hand and then there's on the other hand. When you had to make a decision, I'd like to know whether or not you did consider how to make that decision, because it's not automatic renewal. Secretary, well, as the Director said just now, for most grants, they would be renewed on the basis of the original conditions, but special considerations could be raised. I agree to that. But in the same paragraph read out by the Director, starting from line 5, it said that only certain basic and essential conditions would be amended or inserted where there were serious defects, apparently. So, when it's something basic or essential, and where there are basic omissions in the original grants, we would give the renewal application special consideration. But at that time, after balancing all factors concerned, no additional provisions were added. Well, I think we're looking at history. I have to pursue facts. If you read paragraph 2.10, it's very clear that the two salient requirements were set as early as 1957. They're basic and necessary, if I am to use those two words. And that's what the director meant in the letter. So why am I pursuing this? I'd like to know whether or not you believe those 2 points are basic and fundamental. The two salient points. Salient requirements. Yes, your opinion. Well, can I continue? Yes, please. For this judgment, different people may have different opinion at different times. I believe the Hospital Services Department should have gone through the details and made that decision. Just now I pointed out our interpretation of the facts in accordance with the document. Whether or not we agree to the practice and decision, then we can discuss. Well, perhaps we should no longer spend time on this. When we write our report internally, we can follow up on this. I just want to have an explanation from the Secretary. Can we focus our questions on this first? Kenneth? Mr. Chairman, I'm also reading this document. In this memo, if you read paragraph 2, you'll see what happened then. I'd like to have members concentrating on the last two sentences of paragraph 2.
A serious defect in the existing lease. Mere updating of special conditions to accord with standard clause will not be incorporated. 跟住最尾一句係最緊要嘅，佢話 The suggested modifications are now listed at Annex C attached。嗱，我想問一問啊，呢一句嘢係咪話咧，佢後邊 Annex C attached 嗰啲 examples 咧，就係一啲 basic and essential conditions。
So I just want to know whether or not those were examples of basic and essential conditions. I'm not a proper lawyer, but if you look at Annex C, say on page 3, item 3, page 3, item 3. Would you please read that out?
Ingress or egress to or from the lot for the passage of motor vehicles, except between points A and B, blah blah blah, etc. 咁呢個 remark 就話
So that point is that the grant has to be updated for inclusion of that clause in relation to vehicular access. Well, if this example represents an essential condition, then I do not understand why those two salient points were not essential conditions. Did the Bureau read into the true meaning of the memo? Of course, the Secretary was not the responsible party then. He might not be able to answer the question. Now, those are modification examples. These may be trivial examples, but for such an important condition, if you don't consider that an essential condition, then I believe that's a wrong decision in terms of judgment. Secretary? Mr. Chairman, I cannot comment whether or not that's a wrong decision. I am just looking at the documents and try as far as possible to explain to members the considerations of the Hospital Services Department. Of course, I cannot substitute myself into the scenario then, and I cannot comment on whether or not the decision was correct. Members, any more questions? Alan? Mr. Chairman, when I listened to the Secretary's evidence, I found that apparently he was not saying that the 2 salient requirements should be written into the grant. Sorry, the speaker was off mic. I'd like to confirm this understanding of mine first. Secretary, I agree. That is, if they would like to write that in, they could raise it. All right, then I don't need to ask any more follow-up questions. When we try to take evidence, we'd like to give the Secretary the opportunity to explain the situation. Today, we have this paper R59/4/Gen 3 tabled, and we are to read the documents on our own. Tab C3. Tab C3. I hope that all witnesses are reading the tabbed version. C3. Hospital C land grant 4, right? That's a memo dated the 28th January 1991. Of course, this was what the chairman at the beginning asked the witness to read out. It's dated the 23rd of February 1990. That is after the one in Annex C3. Now, this is a memo from the Chief Estate Surveyor for Estate Management of the Regrant section. You can see the distribution list on page 29. The last item is Director of Hospital Services. Now, from this memo, you can see that the first 2 paragraphs are actually a replication of the memo just now. And then in paragraph 4, it says, well, in 3
of the existing lease at Annex A, together with a location plan for your reference. I would be grateful if you could let me have your reply within 4 weeks from the date of this memo. 嗱，咁呢個咧就係俾咗嗰啲受函嘅或者受呢個 memo 嘅。
So the recipients of the memo had the opportunity to consider whether special conditions had to be added.
咁大家睇到啦 ，DSOK 活概我成日唔係好知呢啲係咩嚟嘅，不過有關係先至講啦。但係總之係。
Well, I don't know what DSOK is, but he would like the official to confirm that the occupied area agreed with the leased area. And then another official, DPOK, should advise the zoning of the subject lot on OZP and ODP. And then C, 2 other officials were to confirm the special condition numbers 3, 5A, 6, and 9 of the conditions of grant had been complied with.
What this document shows to us is the workflow. That is, all relevant officials, in particular, Director of Hospital Services, may insert certain conditions if necessary. And we see from documents that there are reply memos, say for example C4. At C4, there was Ms. Rosalind Wong for Director of Hospital Services. It's a reply to a similar memo. The date seemed to indicate that it's a reply to the previous memo. It's on page 53. The date is 22nd of April 91, about 3 months later.
Special condition number 35A69 of the conditions of grant have been complied with. As regards the breach of the parking space clause, I see no objection to the proposal as contained in paragraph 3 of your memo 38. 所以呢，我想
I would like officials attending, be them from the Department of Health, Lands Department or the Secretary, to confirm whether my understanding is right. That is, as we've heard from your previous testimony, that there was a consideration of a smooth transition to 2047. If, in relation to the two salient requirements, private hospitals would see any insertion or addition, it can be done through this workflow. I would just want to confirm that. The Director, this letter is sent from the department, so I would like to hear from the Director first. Dr. Chan, this is a letter from the Department of Hospital Services. And such special conditions refers to paragraph 3. That is, the special conditions sent to us, and whether they have been complied with. At that time, in Annex C4, that is page 53, the representative for Director of Hospital Services replied that the request for confirmation from the department. Well, Annex C is a memo from Chief Estate Surveyor to the relevant department asking for confirmation that the special conditions have been complied with. On page 53, Annex C4, representatives of the Department of Hospital Services replied in the affirmative. Yes, thank you, Dr. Chan. Secretary, you would like to supplement. The Director has already explained about the correspondence. That is, questions asked in the first memo and the reply in the second memo in relation to paragraph 4. I would like to take the opportunity to clarify that I have never said that there was a policy stating that no addition is to be allowed. What I wanted to say is that there was this spirit, and the spirit was reflected in the memo dated 23rd of February 1990 and the 28th of January 91. And of course, if necessary, they can be inserted. It's just that because of this spirit, they've chosen not to add them. Just now, Dr. Chan, the Director, referred to the special condition. The condition itself was wrong because two salient points, the salient requirements, were missing. So in the letter dated February 90, it says that, however, well, if there are any defects, it has to be corrected. On page 35 or 53, page 53 is wrong. If you refer to the memo dated February 90, you were asked to amend, but you did not. Director for Land, so you're the gatekeeper in relation to land grant. Can you give us more information? Ms. Lin, if you're talking about the document in relation to LG4, this memo was circulated in relation to LG4. One of the salient requirements, i.e. plowback profit into the facilities, it was already there. I believe in that point of time the director needed not touch on that. And in relation to the requirements related to beds, it was not there. And my understanding is that this is in relation to welfare or elderly center. And whether the consideration that at that time it wasn't a typical hospital, well, I will leave the director to answer. So, well, this is in relation to this hospital against whether it is a hospital per se. But when we look at it, we're not looking just at the hospital. We're talking about conditions, lease conditions, used in relation to all hospitals, because previously you mentioned about land leases that is going to expire before 97. That was your understanding. But still we're talking about two salient requirements, and it is not just in relation to this particular hospital. The question asked by Mr. Leung means that it can be explained against other conditions. We have to prepare the report, and this piece of information is very important in our drafting of the report. So we have to tally what you say with the facts. Well, we have to be in a fair manner, investigate and find out what exactly happened. We have to look forward. We have to look forward as to what is going to happen in the future. Alan, I don't think we need to spend more time on this. The director's answer is quite to the point. So from page 1 and page 28, the two memos, you can see that every year when private hospitals asked for a renewal, the chief estate surveyor, estate management regrant section will issue these two memos, as I can see from these two memos dated 1990 and 1991. That is just the basic workflow. And the most important line in relation to our questions about why the two salient requirements, either or both of them, were missing, was in relation to line 3 in paragraph 2 in this standard memo. Which one? Well, on both page 1 and page 28. Let's refer to page 1 first. Starting from line 3 with the word any. I hope that this line will be quoted in our report.
Amendments will be incorporated in the conditions of lease extension or in a modification letter if appropriate. 呢一句呢係喺第28頁嗰個1991年。
This is in relation with the same standard, the same procedure was adopted in 1991. Paragraph 2, line 4. You see the same line. This lends some weight to what the director just explained. the relevant department, so it's the Lands Department and the Department of Health. Yes. If they deem fit, they can reply to the memo of the Chief Estate Surveyor. I think that is sufficient. Alan? So would you please now take us to part 3? Sorry, Director. I would like to supplement certain information to legislators. Annex C1, that is page 1. Page 1. The memo dated 1990. I would like to give you more background information. I'd like to draw your attention to a certain part. Mr. Leung was asking about a chance of renewal. No, that is not the case. That is in relation to a reply.
Under the New Territories Lease Extension Ordinance 1988係因為呢一個 ordinance 咧，而佢需要咧係處理
They have to deal with this premises in relation to this ordinance.
2047，即係呢個唔係每年續牌。
That the office is currently considering the extension of the lease term up to the 30th of June 2047. This is in relation to New Territories Leases Extension Ordinance 1988 and paragraph 2. Our understanding in the last sentence of paragraph 2
are now listed at Annex C attached. Annex C 咧就當時有關部門。
Annex C was a suggestion from the Chief Estate Surveyor. I believe the Department of Hospital Services would comment after they've read Annex C. Thank you, Dr. Chan. Page 28, Annex C3, the same. This is the same. That is dated the 28th of January 1991. I'd like to draw your attention to paragraph 1. This is also
classified as a special purpose lease under the New Territories Lease Extension Ordinance 1988. 咁同樣喺 Part 2最後嗰句咧 ，the suggested
And the suggested modification is now attached in Annex C. And I think the Department of the Hospital Services would comment after reading Annex C. And then you see that the Director of Hospital Services gave a reply to in relation to the special condition that you can find the same information in Annex C4. Yes, I think we're talking about the same thing, Dr. Chan. You are talking about the special condition, but the letters, yes, this is not in relation to the annual renewal. Mr. Leung was very clear that it is in relation to any amendment. What you told us just now was in relation to the special condition. It doesn't mean that there is no amendment. If you refer to the date, to the memo dated February 1990. So on page 1, page 28, and page 53, you've been reminded again and again. Officials at the Lands Department always put a footnote there, asking for your saying that it is your consideration, because this is very important in relation to the lease. We have got the information we sought. Sorry, I'd like to follow up and clarify. Mr. Leung reminded us about the line, any necessary, that the line started with any necessary. I think what is important is the line that followed. However, the serious defects, essential, basics, and they should be included. At the time, the Hospital Services Department did not see the same definition in this line, that it is basic and essential and defects. Director, well, if you have information showing the mindset of the officials, please show us. We cannot consider. We cannot say that they have gone through the process of of careful consideration in vacuum. We will just look at the facts. If you can show us documents showing the process of thinking, then you can show us. May I clarify that at least that is what they thought. And, this was made, this is for the consideration of the HSD, the Hospital Services Department. Well, if you have the document, then show us. That is how we should approach what happened in the past. Alan, can you take us to part 3, please? You have 15 minutes to give us a presentation first. We've completed the first 2 parts. Today, we look at the monitoring and enforcement of land grant conditions, and whether there are any inadequacies in the monitoring work. That will be the main line of our investigation or our evidence gathering. First, I would like to deal with Hospital D for dog. Let's first turn to page 23 in the Chinese version. It mentions Hospital D, LG5. There are 2 important points. Can you find it, page 23? In the table, A, the grantee shall provide no less than 23 beds in the said hospital. Page 23 in the English version as well. LG5, there are further information, that is, Hospital D should submit an annual statement giving details of the total number of first, second, and third class paying patients treated and the number of inpatients treated free. Another condition is related to Hospital D, that is LG6, and it stipulates that not less than 20% of the total number of beds provided in the said hospital at any time shall be low-charge beds. And it further say that the daily maintenance charge of these beds should not exceed the the fees for the third class hospitals in a public hospital. And any other fees to be charged, say for example, X-ray, laboratory consultation and X-rays, emergency services, should not exceed 50% of the relevant class. Well, patients can use such beds, and they should not be long-term cases, and the administration should stipulate clearly the relevant fees to be charged, and that is in relation to Hospital D. So I would like to first clarify that there are such conditions in place.
Next, I'd like to refer the witness to 3.11. That's A1. That's on page 28 of the English version. So it requires Hospital D to provide free or low-cost beds, but then if you look at Roman number 1, well, the utilization of the free beds from 2007 to 2011 ranged from only 17 to 24%. And if you can refer to note 8.2, then the utilization rates were low as compared to, from the years 2008 to 2011. Well, the average utilization rate ranges from 98% to 113%. In other words, almost all beds have been taken up. So comparatively speaking, the general utilization rate was very high, but then for these free or low-cost beds, it's exceptionally low. So my question is, has the department taken any action to make sure that with regard to the utilization rate of these low-cost or free beds, it should be higher, and if not, why not? All right, Director. Para 3.11a, free beds. Well, the DH in the past did not really look at enforcing this term in the lease, and only on this occasion that we put this to the hospitals concerned and we asked them about this. Well, I'd like to give you a bit of background. In fact, the ordinance already came into force in the 60s, and that was the requirement, and according to the Medical and Health Department back then, well, that was established in 1989, and well, in April 1984, the hospital department, according to our records, also never enforced this. And actually, before the DH took over, well, the DH was took over in December 1991, and according to our records, well, for private hospitals renewing their license, there was no inspection whatsoever, and there was no specific enforcement of this. And only after we took over, we introduced the system of inspection and also annual check. And only after we introduced the system, we introduced this code, and we try to enforce it. That's why all along, as we were not aware of the fact that we had the duty of implementing this or enforcing this provision that there should be free or low-cost beds, that's why we never checked it. And only in response to the audit's request that we checked the files, and we only then learned that we had to enforce the 23 beds provision. All right, can you also answer the second part of Mr. Leung's question? So, Ellen, I think she has already answered the question. She did not directly address your question. Well, she just said that they never enforced it, and only after 1992. Did you ever do it? No, it's only this year. Why not? Do you know why? Because during the transition, well, in the past, there was never any documentation on this, and only after we took over, we introduced this inspection system. But then we did not know that there were 20 free beds, and there was this requirement. But then apparently when we referred to the memo in 1991, that is in Annex C1, well, those were the lease terms, and you were supposed to enforce it. So you also told us that you already had those terms available. So you did not know it. Well, for the 20 free beds in this particular hospital, we never enforced it. All right, Ellen. Well, Chairman, my understanding is that, well, when they started the review work on number 59, when they started the audit, by now the DH in its inspection, there would be this new questionnaire or the so-called checklist. So this is an inspection checklist, and mention would then be made about the lease terms, and therefore during your inspection of the hospital, you should also find out if they've complied with the checklist items. But then, according to what you said just now, apparently you did not note that in the lease terms whether they had been fully enforced. Is that right, Director? Chairman, for the 23 beds, yes, that's true. We did not enforce it. But then for the low-cost beds, we did look into it. But then starting from this time, in a questionnaire that we give to the hospital, and also in the course of inspection on the checklist for the inspectors, we have already included this requirement. Can you explain a bit more? So for the 20 free beds or low-cost beds, well, 20 free beds, they are free. So that's stated in 3.11. That's for Hospital D. And then for the low-cost beds, well, that's in the other leases. For example, Hospital D, item 6. And for low-cost beds, we did enforce it. But then for free beds, we only started to enforce it this year. Mr. Leung, Well, that was actually the point that I'm getting at about the low-cost beds. And if I can refer the witness to the audit report. Which paragraph? F. Well, in F, it says that although the DH was obliged under the land grant conditions, the HD has the responsibility to come up with an agreement with the hospital, but then the HD did not do so, and also did not make any reference to how patients would be referred to that hospital. And also, if you can look further down, for Hospital D, actually came up with certain criteria on its own. And for example, it says that the patient will have to be permanent residents holding valid Hong Kong ID cards, and they should also have an admission letter from the hospital's residence doctor or visiting doctor, and those in possession of medical insurance policy would also be entertained. So my understanding is that those were the conditions that the hospital came up with on its own. There was never any discussion with the DH. There was never any consensus with the DH, and those criteria were never announced. Is my understanding correct? Director. Well, Chairman, the situation is, well, for Hospital D, the provision is that there is the requirement for 23 beds to be provided. That's in the lease terms, and the DH has been liaising with the hospital in question, and the DH did ask the hospital to step up publicity so that the doctors should be made aware of it. For example, the hospital also reported to us that, for example, in 2008, it did write to the management or the cluster chief executive of the HA with regard to the package on these low-cost beds in these hospitals. So different clusters were informed. And then in 2009, initially with regard to the low-cost beds and also the information about it, well, that would only be given to the resident doctor. Subsequently, letter was sent to all visiting doctors. With regard to the agreement to be reached with it, we do not have any standard or standing agreement. But then in 2009, in May, that's the time when we had the swine flu attack, we also asked the hospitals to agree to provide 60 beds to the HA where necessary, so that for rehabilitation or convalescent patients, they can also go there. But then as there was no such need, therefore they were never actually used. So we did enforce the requirement, and they were asked to provide these low-cost beds. With regard to the utilization rate, well, when the utilization rate was low, we asked them to step up publicity with the visiting doctors, and as a result of that, it went up subsequently. So you did try to do it, but then according to the DH, well, they did try to do it. But then after you make those impose those requirements, what's the response from the hospital? Did they comply with your requirement? And did you follow up on that? And did you monitor their performance? So, Chairman, I'd like to say that, well, since we started our hearing on the audit report, since we started to collect evidence, well, some readers or some TV station tried to interview a private doctor, and he said that he was never aware of it. He was never aware that private hospitals were required to provide these private beds, and another doctor said that he was aware of it. But then he also said that he attempted to refer a patient to a low-cost bed because the patient did not have sufficient means. But then he was not able to get him into the hospital. So for apparently, well, this is also a supporting evidence. Yes, on the one hand, you unilaterally imposed the condition, but then the hospital just turned a deaf ear to that, and you did not follow up by monitoring what they did. Is that right? Chairman, I'd like to supplement on the question raised by Mr. Leung just now. I'd like to supplement on it, because just now Mr. Leung said that, all right, on page 32, F123, under F, and he wondered whether or not they were just proposed by the the private hospitals on their own without consulting the DH. But then with regard to item 3, those in possession of medical insurance policy would also be entertained. Well, that was in response to what the department did after taking the matter up with them, because the utilization rate was low, and initially the private hospitals would say that for those with medical insurance policy, they felt that they can afford it, and therefore they did not accept such application. That's why this condition was inserted into it. It's not done by their own initiative, because we wanted to have more patients who can use those low-cost beds. All right, what about the question asked by Mr. Leung? You've already clarified another point. Can you answer another question raised by Mr. Leung, Director? Well, can you repeat the question? Well, Alan? Well, unilaterally impose those conditions, but then through what mechanism would you be monitoring if the hospital had complied and consistently implemented those conditions? Can you tell us what they are? Well, as to whether or not they would comply with it, well, under the land grant conditions, then for the low-cost bed, it would charge $100 per day, and then for the others, that would be equal to no more than 50% of second-class beds in the private hospital. Well, in the course of our inspection and also during our random checks, we would also ask for receipts to make sure that they would comply with this land grant condition. So we did conduct random check. With regard to the low utilization rate, we also communicated with them. In fact, there was also a practical situation. Well, yes, the bed might just cost $100, but then for the other cost is only about half of the second class bed. But then this might not still be cheap to an average citizen, in particular the doctor's fees and charges, because that were not covered by the package in the land grant condition concerning free or low cost beds. That's why we can see that for the low usage rate, that's because the cost would, comparatively speaking, be higher than that for public hospitals. That's why, in particular, for the referral cases from the public hospital, the utilization rate has always been low. Well, because of limited time, I can only ask this. I'd like to put this to the director or the bureau director. Well, Roman F3, and also as the director just said, they would be getting the receipts, and if the receipts do not comply with the land grant condition, then they would follow up. So do you have any documents to show that? Because I've never seen that, and in the audit report no mention was made about this. So if you would like to prove that indeed you have done it, that you have already done the monitoring, and you would also like to give an account to the PAC as to what form of monitoring you have adopted, and also what the mechanism is, and whether or not it's effective or efficient, then I'm afraid you will have to provide more record in black and white. Director, do you have such documents available? Well, for receipts, yes, we can provide that because we did ask for that. With regard to those possessing medical insurance policy, what we can provide is, well, that's the condition that they offer, but then there is no evidence to show that they have done so in response to our request. But then at least there is this policy to show that they are willing to take up cases involving medical insurance policyholders. Well, I think you can see that in the process, the DH, well, initially might not have been aware of a particular hospital where it should provide 20 free beds, but then in other areas, well, 20% of the beds should be low-cost beds. The DH did was aware of it, and it did take it up with private hospitals. But then I'd like to point out that despite the fact that these private hospitals did offer such beds, but then for various reasons, for example, they might have provided it, but then patients might not be aware of it. But then what about the doctors? Did they know about this? And also they would also have to understand the overall cost. It's not just about the cost of the bed. With regard to the fees and charges of the private hospital, the patients might still think that they cannot afford it, and that's why the utilization rate has been low. That's why in the process, when we talk to the private hospitals, we have been asking them to think about it. What ways can they use to increase the utilization rate? And in the course of the swine flu, well, the HA also said that where necessary, they can also make use of those beds. But then, if you ask whether or not the effect has been good, well, it might not have been very good. In other words, after taking all those measures, we have not been able to increase the utilization rate. That's true. Mr. Leung, I think I've already made it clear. Well, I like to put this as a preamble. That is when we prepare our report. Well, before we prepare our report, you can also provide us with further evidence to show that you have already done something with regard to the low-cost beds, that you have already done your monitoring. So please do provide us with the information as far as possible. Next, Mr. Raymond Wong, Mr. Gary Chan, and then Mr. Ng Long Sing. Thank you, Chairman. In Part 3, we are mainly talking about 5 things. And the first is about the DHA inspection to make sure that they comply with land grant conditions. And number 2 is the provision of free and low-cost beds. And 3 is about the reinvestment or plowing back of the surplus or profits into the hospital. All right, that's very clear. And just now, some examples have been quoted, and I don't want to repeat them, or else other people might complain that I'm dragging my feet. But then there is also mention about the non-profit making hospitals. That's Annex A in the report. You can also refer to it. Appendix A. That's the 1981 condition. That's because the one that was signed in the 1950s was already outdated. That's why, in accordance with the Lands Department's directive, and that's a document, so it's not that the Lands Department has given the instruction to the Executive Council, but then they said that starting from 1981 March, they will also have to include this as a condition, as part of the condition to private hospitals. And from A to J, we have all these conditions here. So you can basically divide them into 2 parts. So for GHI, according to the report, that's in page 71, and this is about the DH monitoring of private hospitals to make sure that they comply with the land grant conditions. So my question is, given the fact that for free and low-cost beds, and also for the plowing back of any profit and surplus into the hospital, so these are the 2 main salient requirements. So those have not been included as the land grant conditions. So with regard to the 1981 condition, when compared to other land grant conditions, all right, for the 2 conditions, we found out that in many cases they had not complied with these conditions that can be found in the report. But then, given the very detailed requirement in 1981, all right, this is a supplementary land grant condition, and they've already found out that there were so many problems. So given this.
Apart from free and low-cost beds and reinvestment, can you tell us something about these 1981 requirements and their implementation? And what about your monitoring work? Secretary or Director? Director? Mr. Chairman? Well, the guidelines from the Lands Department were actually to summarize what the EXCO endorsed in 1981. We previously discussed this issue and submitted some supplementary documents to members to see why, in certain cases, conditions were to be added but were not added. And in the first few hours of the hearing, we're actually explaining our considerations of the documents. Well, yes, we've considered the documents and the 1981 requirements, but then implementation varied from case to case. How could you ensure that the inspectors of the Department of Health could understand these different conditions for different private hospitals so as to make sure and check whether or not they followed the requirements. Well, Director, you have to understand what Yokman is asking. Just now you mentioned in paragraph 2 the conditions to be added. Well, Yokman is asking about monitoring. In 1981, another document was published. So whatever the conditions, he would like to know something about monitoring. I think you should answer his questions. Director. Well, 6 months of handover fee to the Director of Health. We spent a year on that. That is, after we took over, we introduced the inspection regime, and that took a year. No less than 20% of the beds were to be low-cost beds. That's in Grant 6. We randomly checked the invoices and bills and receipts to whether or not there are no less than 20% of low-cost beds. As for E, just now we mentioned that under special conditions, the hospital authority, under very special cases, might not be able to cope with its workload, and it could coordinate with private hospitals such that they would provide some low-cost beds to us. And then there are these annual reports. In 1979, the hospital authority already regularly asked for utilization rate statistics. So that's a half-year cycle. Yokman, well, Mr. Chairman, they said that they explained this in session 2. In fact, the report itself echoes itself in various parts, although we're in part 3. Now, for the report, we have this response of the Director of Health to Audit. That's in 2010 September. Because there were these compliance guidelines for inspection, and the details should be included and covered by the inspection regime. Now, we are worried about, or we are concerned about the different scenarios of implementation of the 1981 requirements. So how could you prepare the checklist? Well, just now, when we discussed Chapter 3, we already submitted documents to you to explain that we accepted the recommendation of the audit and added a checklist to the guidelines to facilitate hospital inspection. Well, your response was a standardized checklist, a checklist in accordance with the land grant for individual hospitals. So that's not a standardized checklist. Would you please refer us to the provision concerned, such that the Lands Department had to follow the checklist items in inspection? Then we will understand that there is this standardized checklist, as you said, because hospitals differ from one another. Well, Mr. Chairman, some checklist items are applicable to all hospitals. Well, that's not standardized then. And then for the details, for example, provision of no less than 20% of low-cost beds, we stipulated that only 2 hospitals were to do that. That is, under a standardized checklist, there are detailed provisions for individual conditions for individual hospitals under the land grant. Now, 3.4, paragraph 3.4 of the report. Is relevant here. The director told us that later they discovered the special conditions and tried to act accordingly. That's not sufficient. Well, I think the administration should look into advisories, warnings, or other actions in which the administration considered taking back the land grant. Now, paragraph 3.4 is on inadequacies in DH's compliance checking. It doesn't matter what they fail to do. You should now do it, and you have to check why they did not comply with the provisions. For this audit report, when the audit conducted checking, well, the two of you were not in office yet. Well, we're not saying that these things must concern you. What concerns you is that you have to rectify previous mistakes, and we expect some new measures from you. So what about advisories and warnings issued as a result of non-compliance? Did some hospitals have some non-compliance actions such that you had to rectify the land grant conditions? Well, I think you have to tell us what documents there were on this subject. Mr. Chairman, concerning the usage rate of low-charge beds, we had not issued any warning. In future, in the course of review, but you had these after September 2012? Well, in 2010, we carried out a comprehensive review on private hospitals. Chapter 3 mentioned how we carry out our checking and how the checklists were compiled. We did monitor the low-charge beds, and the surplus must not be used for other purposes. And starting from the end of 2010, we required private hospitals to submit audited accounts to prove compliance. Financial reports after 2011 do carry audited accounts to prove compliance. So we made some improvements on stringent checking. Yokman, you don't have any other questions? Oh, let me ask one more question. Sorry, Mr. Chairman. Well, if you read paragraph 3.4 of the report, you'll see that only in recent years did they step up monitoring in terms of compliance. Well, after you discovered the inadequacy, you did something. One is about financial condition, another one about donation. However, both did not cover the implementation of the 1981 requirements. That's what I can say. There were discussions involving Grant 5 and 6. In fact, the hospital, the HSD did not carry out any inquiries. It seems that between the Department of Health and the Hospital Services Department, there seemed to be some tacit agreements. There are partners, cooperation partners, so you forgot that you're actually a monitor. Now, before April 2012, that's what I'm asking for. Starting from March 2012, you asked for reports and details. But then you see there were problems with Hospital D involving Grant 5 and 6. As I said, there seemed to be some tacit agreement between you. You can tell me there's no such tacit agreement. Well, we received from the hospitals audited accounts to verify compliance. But after that, we invited them to clarify certain points, and that process is still underway. Well, we asked for accounts between 1997 to now. We must have the audited accounts to prove compliance. Well, they've already submitted the documents to us, and we're studying them. And we'll study them together with the Lands Department. If there are non-compliance, we'll follow up. Well, on the provision of no less than 20% of free beds, Hospital D gave you some data. Please refer to 3.11a. If you read that paragraph, it's very difficult to judge whether or not the condition had been complied with. Well, the utilization of the free beds from 2007 to 2011 ranged from 17% to 24%, which is on the low side. So did you check whether or not there's compliance? Director, have you found that paragraph is 3.11a? Now, 3.11a is about free beds. We already asked the hospitals to provide the information, and we're studying them. We're talking about free beds, yes, because this was only implemented this year. We've already asked the hospitals, the hospital to provide us with suggestions on how to implement this 20 free beds. Well, let me continue. The checking model adopted by Hospital D might render this provision of providing 20 free beds tantamount to nothing. Well, Mr. Chairman, we did not have the information then, so it's difficult for us to check, but we'll stringently monitor the situation and make sure that the hospital provide those free beds. Well, I have to summarize. It doesn't matter, I can give you time, but you cannot have exchanges directly between yourselves. Well, you did not do that in the past. You're now going to do that. The beds are to be free. But what about other fees and charges as well as doctors' fees? If they're very expensive, it's useless to have free beds because the patients just don't use them. Well, that was already asked. Be it free beds or low-cost beds, there are other fees and charges not covered by the grant, such as doctors' fees mentioned by you. So they have to identify ways and means to address that. Well, yes, that's why I said this is tantamount to nothing. So what about implementation and compliance? I understand. You've asked a very good question. Well, these 20 free beds are tantamount to nothing. Yes, you've, Director, or Secretary, you said that you had done a lot of things. Please continue. Well, Mr. Chairman, it's a fact that the usage rate is low. As for Mr. Wong's question, there are two aspects. One is about the future. In future, when we renew grants or consider new grants, we may not use the same method again. Secondly, if there are these conditions now, we have to implement them. So if the hospitals themselves are not thinking about this, then we have to think for them to see how we can enhance the usage rate. Well, Director, what about the 4 sites to be granted? Can you say something about them? Will there be ways and means to make sure that the patients will benefit? Mr. Chairman, the situation has changed. It's not like the past. For the newly granted sites, we no longer adopt the concept of free and low-cost beds. We use the other ways and means. So, Yokman was correct, right? Mr. Chan Hakan? Chairman, well, when the director answered Mr. Wong Yokman's question, she said that in the checklist it would be noted whether or not a hospital has to provide free or low-cost beds. Well, that's of course a good thing. In the long run, we have to look at the land grant conditions. However, even if a hospital observes the land grant conditions, there are still problems. For these free and low-cost beds, as Mr. Wong said, they're tantamount to nothing. Well, I'd also like to refer you to paragraph 3.11, but point D. Now, the hospital has to provide no less than 20% of low-cost beds, but then it's not stipulated in which wards these low-cost beds be, or low-charge beds be. The types of beds are not stipulated. Now, there are two problems here. A private hospital can place these low-charge beds in the general wards, which do not generate much proceeds. But for the gynecology department, there may not be any low-charge bed at all. Then the hospital can make the most profits. Secondly, when the Department of Health inspects a hospital, the hospital staff may just point to one bed and say, oh, this is a low-charge bed. And they go undiscovered. So is it like what Mr. Wong said? The so-called low-charge beds are tantamount to nothing. Well, I think we have to adopt a mutual trust attitude. Well, I understand that 17% of the beds are low-charge beds, but systemically, we should do something. Well, you can point to loopholes, but don't criticize the hospital staff. Well, I was only citing an example. Secretary, the whole discussion here indicates that low-charge beds or even free beds do have implementation problems. It's not just difficulties on our part, but also on the part of the private hospitals. Well, there must be people to fill the beds. So, to respond to your question about whether or not these beds exist and are used. Now, in future, when we grant land sites to private hospitals, as I said, a new model would be adopted. But for the existing private hospitals, since there are these grant conditions, we have to implement them, enforce them. We cannot point a gun at a private hospital and say that, oh, you must comply. Oh, you mean you have to intervene? Yeah, well, in the course of intervention, all parties concerned have to identify solutions such that through previous grant conditions, we could plow back public resources to the public.
So what is the result of the consideration? We are in discussion with the hospital authority on referral mechanism, the types of patients to be referred, and also payment arrangements. Do you have any documents to show us, showing that you are discussing it with the HA? Now, we have yet to come up with a proposal. Now, just now you talk about referral. I would like to follow up on that. If you read note 9, under paragraph 3.11, there is already a referral system in place. If you go and ask any members of the public, 9 out of 10 of them will not know that there are free or low charge beds in private hospitals. With prices being so high, and if the public know about these low charge or free beds in private hospitals, I don't think the utilization rate can be as low as 17 to 24%. I think there is a lack of transparency. If you refer to note 9, that there is a social worker referring cases, well, I am talking about social workers attached to hospitals. Do these social welfare workers know of the low charge beds themselves? And if there is no designated low charge or free beds, how can the social workers know whether there is any availability of such beds for referral? Sometimes the social workers will not want to go into the trouble to find out, and they simply refer the cases to public hospitals. Secretary, I think you're referring to 2 points. First, whether social workers know of the actual information. And I think what you're saying actually points to one thing. There are many factors contributing to the low utilization rate. Information availability is one of them. That's why we have to intervene and think of a way to improve the referral system with the HA, the hospital authority. When I talk about referral, I don't just refer to those ones done by social workers. We're trying to explore different ways to benefit patients. We don't want a patient to go and use such beds, but are subject to high charges in other areas, because that will be a disincentive. This will discourage patients to use these beds. We think at the moment there are inadequacies. That's why we decide to intervene to improve the referral system. Mr. Gary Chan also asked about designated beds. I don't think he understand what you're trying to say. If there are no designated beds, people who do the referral, say for example social workers or government or civil servants, where do they find information so that they can be made available to the public? If there are no designated beds, there may be the situation when a referral is made only to be rejected, and social workers may simply not go through the trouble and refer the case to a public hospital, and that means this referral system and the low charge beds will be wasted. If we ask private hospitals to designate a certain bed as, say, low cost or free charge or free beds, may not be in line with the operation of the hospitals. Most of the time, unless you're in a private ward, patients of similar illnesses, say for example, those who will undergo operation will be in the same ward, gynecology and obstetric patients, gynecological and obstetric patients will be in the same ward. If in the same ward you have surgery, you have patients for surgery, patients for medicine, then it will be difficult for the hospital to know in a very short time what section the patient referred what sections the patients belong to. And I think that there will be more flexibility if we just stipulate the total number of such beds. But still, we find that to be inadequate. Otherwise, we wouldn't have wanted to intervene. What about social worker referral? Those stationed at hospitals. For those resident social workers, they are attached to the private hospital. When patients are admitted, there will be a leaflet, an information leaflet, giving all the information, including subsidized beds and also 20 free beds available. If necessary, patients may contact the social worker. And when it comes to doctor's charges, that will only be available when your doctor in charge tell you. But we have a low utilization rate of 17 to 24%. And when you refer to social workers, you're only talking about social workers resident in private hospitals, not those in public hospitals. That explains the low utilization rate, because you're working for the private hospitals, so you won't be referring businesses that will make your boss suffer a loss. Sorry, social workers are social workers. They have a code of practice to abide by, so do not doubt them. Do not doubt their ethics. A very simple question, a last one. 3.11. Hospital D. In June 2008, they were only required to provide 20 low-charge beds, which is a lot lower than the original requirement of 110. Maybe there are difficulties encountered by the hospital. But there may be another scenario. It may be the case that the hospital is reluctant to provide as many low-charge beds. How come about a year and a half later, that is October 2009, when the Department of Health inspected Hospital D, it was only then that they realized that the Hospital D did not comply with this requirement. And at that time, well, the Hospital D still failed to provide a sufficient number of low-charge beds. So for a prolonged period of time, Hospital D did not comply with this requirement. Why wasn't it follow up? Why wasn't Hospital D required to gradually increase the number of low-charge beds? Putting in place low-charge beds in phases. Well, as relayed to us by the hospital, they said that they will first they were doing some kind of redevelopment, and they need time to move the patients from the old wing to the new wing, and they asked us to give them time. In relation to the 98, there are 98 low-charge beds. There are two that are kind of flexible or standby. They were to renovate the old wing. Some patients will have to be moved or relocated to the new wing, and they ask for time. What about timetable? When will they reach 110? Have they given you any timetable? Yes. Then can you give us the information? That was October 2009. So by October 2009, there would be 100. Any other questions? No. Mr. Ng Lang Sing. I have a suggestion for the secretary. I don't have the exact figure. Low utilization rate of free beds, just over 10%. Are there any cases with a high utilization rate? Can you give us the figure? There is a requirement of no less than 20% of low-charge beds in private hospitals. Are there any private hospitals that have complied? Can you give us the information? For those hospitals who have complied, we can draw reference from them. Do they have a good referral system? Do they have good communication with the community? Is it because the private hospital was determined to comply with this? That's why they have put in place facilitating measures for these beds to be used? Director, currently 2 private hospitals are required to provide low-charge beds. They are hospitals D and F. I said in the last session, a ward accommodating over 5 people cost 500 to 600. And in relation to referral cases from hospital authorities, in relation to laboratory services, a 30 to 50% discount will be offered. The utilization rate of beds with those conditions I've just said is just over 60%. So it's it is higher than the low utilization rate we've mentioned. So obviously there are some good practices. Other hospitals can learn from that. They can be maybe put into a guideline. Are there any other guidelines in place? We agree with the spirit of what Mr. Ng said. If utilization rate can be boosted up with by different ways, then of course it's worth taking reference from that. But so far we only have few examples, and the performance hasn't been to our satisfaction. We will explore other ways for that to be improved. Mr. Ng, now I will ask questions, starting from 3.6. In relation to the new measures, that is the compliance certification of by auditors. In paragraph 3.6, it says that the arrangement related to the certification leaves room for improvement. Well, you have the measure in place, and in relation to you ask the auditors to monitor the compliance of land grant conditions or financially related requirements in the land grant conditions for you. They are auditors by profession, and you give them 2 tasks in relation to medical services and land grant conditions. Are the auditors in a position to understand and fully informed of the land grant conditions? Do you have close contact with the auditors to enable them to monitor them for you so that they can easily spot non-compliance? In A and B, you have made some observations that there are inadequacies. Is that a result of the new measures that you find these irregularities? After the practice direction has been put in place, private hospitals are required to provide an audited account. In 2010, there was a review to enhance enforcement compliance. We specifically asked for an addition that land grant conditions are complied with. In page 21 of the Chinese version, well, take Hospital D as an example. In August 2011, when the hospital was asked for the auditor's certification, the situation of the 20 beds was not highlighted. So, apart from confirmation of compliance of land grant conditions, we require them to specify the individual conditions. Your questions is very good. Paul, what is from the perspective of the role of an auditor? I think in the company's bill we have touched on the auditor's role in monitoring compliance on land grant condition. Can it be done? You may choose to answer or not, but you've been a legislator and you are a professional and you vetted the company's bill with us last year. Secretary, I think that is feasible. And when the auditor is doing the work, that will not just be a general auditing of financial statements or reports. But this will be a special audit. And when it comes to such assignments, it depends on the brief you give to the auditors. If there are specific requirements under the land condition, say for example percentage of low charge bed, and also the charging arrangements, assuming records of utilization of such bed has been kept, this can be done. I think just now Mr. Ng's question wasn't answered. And it gave the impression that it couldn't be done. That's why I asked Paul to answer. Thank you. If you just want to get a line from the auditor as a confirmation, and then you base your decision to approve to renew or otherwise based on that, I think you have put the responsibility on the auditor. Will that be flawed? What if the auditors err? I do believe that there are inadequacies in the current system. Can you look into it? According to the director, the auditors are just asked to tick against a few boxes, say for example, compliance with low charge beds, plowback. Perhaps the auditors are asked to tick against a few boxes. there is an inadequacy. Have you done anything to address that? You're not just using the auditor to give you a confirmation for you to complete your monitoring work.
Yes, we've been making improvements, and in the process we've also added in this additional clause that the auditor will have to check for compliance to make sure that the hospitals in question have already met the land grant conditions. But then, if we had been able to communicate effectively with the auditors so that they would know our requirements, and if the hospitals concerned are required to keep proper records, then the auditors would be able to find out and verify those figures, then that would also help to give us a better assurance. But then, since the Enron incident, auditors no longer take up any responsibility. The only thing that they would be prepared to do is to check the documents that you asked them to check. And that was the reason why Mr. Ng has brought up this fundamental question or issue, because this is a responsibility that you cannot possibly pass on to somebody else. This is about the delegation of responsibility, but then it cannot be delegated. That's why the issue that Mr. Ng has brought up just now is that, all right, after you have asked the auditor, who was an independent third party, you are asking him to verify this, but then the auditor might not be able to certify whether or not the hospital has complied with your requirement. That's why I think in the future, all right, for the issue brought up by Mr. Ng is not that you are not required to answer the question, but then this is a basic responsibility, and therefore when you do it, you will have to make sure that the list of items in the checklist are things that they are able to do. So this is a very practical issue that you will have to consider. This is also very important, says the Bureau Director. Well, Chairman, I think the Enron incident is an isolated case. Thank you very much for reminding us of that. I believe that in the further work to be done, the DH, in asking or commissioning the auditor to do it as a special project, well, I'm not speaking to you as a Bureau Director of the Development Bureau. I'm asking you as a professional accountant. Yes, I understand that. That is for the entrustment. You will have to get it in the engagement letter. And also, we also have to agree upon the procedures. And so long as those are clearly defined, then the auditor will be providing assistance to the DH so that he would go to the front line with regard to the information provided by the hospital and also the documentation. The auditor will be giving a report back to the DH. And then when you read the report, Bureau Director, for the independent third party, that is the auditor's report, have you really thought about this? That is the engagement letter as brought up by the Bureau, the Development Bureau Director. Well, you just read his report, but then you have not really seen the scope of his work. That's the issue brought up by Mr. Ng. It's a very practical issue, and it's quite an important issue. And if you just adopt the approach that you said to monitor the performance, then it's not good enough. And also in paragraph 3.8, I'd like to verify the relevant responsibilities. And also that in the middle of the paragraph, it says that the DH further sought clarification from the Lands Department on the application of the profits and surplus plowback requirement to see if they have complied with the land grant conditions. So I'd like to know if they've already put in place rules and mechanisms to ensure that there is this procedure. That is, the DH would ask the Lands Department to check for the implementation or compliance of land grant conditions. And the Lands Department would be asked to give advice to the DH. So can the DH also confirm that with regard to the application of the profit surplus plowback requirement, whether it applies to the entire hospital or to only those parts of the hospital on PTG sites. In mid-September 2012, the Lands Department provided the DH with its advice on this particular point, but then as at late October 2012, that is the time shortly before the publication of this report, the DH was still following up on the issue. So I'd like to know, with regard to such duties and responsibilities and also your division of labor, is that very clear? And second, with regard to the provision of advice and also the powers to give advice or the duty to give advice, so to what extent is that the responsibility of the Lands Department? Should it be the DH, which ultimately, after looking at all the advice that has been given, is the DH which will be making the final decision? So I'd like to get the answers for these 2 points. All right, the 2 directors and then the bureau director, because it involves the duties of the 2 directors. Well, Chairman, currently is the DH which will be accepting the audited report from the hospital that's been implemented. We have already made it clear that they will have to have or include the auditor's certification that the hospital has already complied with the land grant condition. And also in para 3.8, we have also communicated to the Lands Department, because for the use of the land, it might be more complicated. For example, there is a hospital which is using 3 sites. One is privately owned. The other one has certain land grant conditions, and for the third one, there is no such requirement. And therefore, we will have to ask the Lands Department to look into the land grant to see if that only covers the part of the land on the PTG site or the entire site. So after this interpretation by the Lands Department, we will have to get the accounts from the hospital, and then first of all the DH will look at the report, and then we will have some initial analysis, and then we will ask the Lands Department to give us its advice, and then after the Lands Department has given us its advice, then we will be able to verify it. All right, Director for Lands. Chairman, with regard to the mechanism, with regard to the enforcement of the lease, is a private treaty grant, and therefore every time we will look at it as a case, a specific case. And therefore, what is happening right now is when the Director of Health is in possession of certain information, and after she has done the analysis, we will have to look at the facts of the case, and then we will give the DH, who is the enforcement agency of the land grant, she will have to look into it in a particular way. That's why we do have a role to play. But then as regards the point made by Mr. Recently we have been asked by the DH on a particular case, and we were asked to give it advice. And as the director just said, sometimes the hospital might be sitting on several sites, and as a result it is operating on several sites. On the one hand, we do have this surplus profit plowback requirement, and on the other side there is no such a requirement, and therefore how should that be enforced? We have actually sought legal advice on that, and after we have sought legal advice, we have already given a reply to the DH, that is, we will have to act in accordance with the land grant, so that with regard to that particular site and also the lease in question, whether or not there is such a requirement. In other words, if we want to know whether or not the hospital has reached the relevant land grant conditions, first of all, we will have to find out how it divides its profit, how much of it would come from a particular site where there is such a requirement, and then on a particular site where there is no such a requirement, before we can tell. The spirit is that it's a PTG site, and therefore we will have to look at the site. We can't say that, well, even though that site does not have this condition, but since it's linked up with another site which has this condition, you will have to comply with it anyway. Constance, or Dr. Chen, can I refer you to para 3.7 in the audit report, and the question that has been raised in para 3.7 in addressing the point made by Mr. Ong Leung Sing. So can you explain to us how you respond to the point made by the Audit Commission? In particular, the last part of it. Can I read that out?
Clearly, the requirements, the auditor's certification might fall short of the Director of Hospital expectation. This is evident from the following inadequacy noted from the auditor's certification submitted by Hospital D， 即係喺個，即係我哋用呢個嚟你睇你成個。
So we judge it from the this we see if when we see if the entire system is working, then we will have to see whether it works in this case, and therefore we have to be forward-looking. And we are now trying to see how you resolve this problem. All right, the Lens department has already responded to that, and you're resorting to the system in order to resolve this problem. So how are you doing? How are you able to do it? Well, Chairman, in the past, that is in 2010. Before we conducted the review in 2010, we only received the auditor's account. So that's the audited, that is the set of accounts as checked by the auditor. But then after 2010, we believe that the situation had to be made clearer, and that's why we asked them for an auditor's certification confirming that the hospitals have already complied with all the land grant conditions. It's just a general statement by the auditor. We have already accepted the advice that it's not adequate. Well, what do we mean by complying with all the land grant conditions? So we will have to refer to the relevant lease with regard to financial related requirements imposed by the DH. And in the process of verifying this, the auditor will have to check the land grant conditions in the first place, and that's a very substantial improvement. So there will be a checklist listing out all the items. So they will have to comply with all the conditions, and there will have to be very clear answer as to which condition they have met. Yes, it's not just a general statement. They will have to state that they've already complied with items 1, 2, 3, 4, 5. Yes, Mr. Kwan, can you give us an example of the certification? I'd also like to follow up on the point made by Mr. Paul Chen with regard to the engagement letter of the auditor. I'd just like to state that Mr. Paul Chen was stating that from the professional perspective, he was just assisting us. I'm not asking him. I'm asking the director. I just saw this advice. Yes, thank you. Well, in 2010, since October, after they have introduced this new requirement that the auditor will have to provide this certification, I was just asking for an example, whether they had a sample of that. So I'd like to ask if the DH had talked to the auditors of private hospitals. Was there any direct communication or meeting or interviews? Well, Mr. Paul Chen also gave us some professional advice, and he said that in the engagement letter, there could be specifications as to what the private hospital's auditor would have to do in order to issue this certification or certificate. But then with regard to this engagement letter or this agreement, well, that's a contract between the auditor and the private hospital, and therefore the DH has no role to play in this engagement letter. So can the DH tell us more about this? Yes, Director. Yes, to answer Mr. Kenneth Leung's question, it's true. We did not have any direct communication with the auditor of the hospital in question, but then we asked the hospital to provide us with an audit with its auditor's certification confirming that the hospital had complied with all the land grant conditions. So we did not communicate directly with the auditor. So he's an auditor appointed by the hospital. He's not chosen by the DH. But then we asked the hospital concerned to submit an auditor's report, which will have to certify that the hospital had already complied with all the land grant conditions. Chairman, I'm still on the issue about the auditor. I also hope that, with your permission, I would also be able to extend this to the requirement on plowback of surpluses into expanding or improving the hospital. I would also like the audit director to provide us with further information with regard to the 11 private hospitals, with regard to the auditors hired by them. Are they all very different? So they are raw individual auditors. They are all different. They are different persons, right? Yes, they are different. Confirmed the audit director. So the directors themselves might also have different auditing procedures. and they might also be able to give you the same certificate or a similar certificate in the end. But then as to what they have done in the process, what documents they have checked, we have no idea whatsoever, right? So it's really a black box operation. Even though we do trust in our professional auditors, we believe that they would do everything that is in line with the professional code. Still, the DH would be placed in a very passive position. So can the DH think about this in the future? That is with the agreement of the private hospitals, can you directly talk to the auditors? Can you even meet the auditors? Can you even consider that in the future, under the auditing procedures, there can also be certain requirements? Director or Bureau Director? Well, basically, I agree that on the one hand, this is not just the hospital's responsibility, it's also the DH's responsibility. But then the appointment of auditors would be the responsibility of the hospital, and therefore the DH can only issue a guideline to the hospital telling them that I'll be asking for certain evidence, including what the auditor will have to do in the process of auditing. But then it's the hospital that will be giving the instructions to the auditors, and therefore there is no question of the DH giving instructions to the auditor directly. But then on our part, we can also clearly let the hospitals know what our requirements are, so that they can also in turn make sure that their auditors, in doing their auditors' work, would be able to comply with our requirements. Yes, Kenneth? All right, after listening to the Bureau Director's reply, I'd like to look at the wording in the auditor's certification before I follow up further. But I'd just like to come back to this issue, and I'd like to bring it to this requirement, that is 3.12, about the plowback requirement. 3.12, we can see that B, C, D, and F. That is 3.12, B, C, D, and F. There are requirements, that is A to D, requiring that this hospital will have to plow back its profits and surplus into the hospital, given the fact that we have offered land at such low cost or at new cost. Such profits or surplus should be plowed back into expanding the hospital instead of being used to distribute or issue dividends to the board of directors or the sponsoring or the operating organization. But then from this we can see that with regard to the grantee, it might not have been the hospital itself, because the grantee might be the parent organization of the hospital. So I'd like to ask a factual question, and the audit director might be able to answer the question. With regard to the hospitals in question, where they have this profit surplus plowback requirement. So are all the parent organizations registered charitable organizations? Audit Director. Chairman, according to our understanding, yes, they are registered Section 88 organizations. Then I'd like to know this further. I'd like to put this to the Director or the Bureau. Well, just now, we asked where a hospital is sitting on two sites in its operations. For example, if I can refer to, say, Hospital B in B, 3.12B, well, Hospital C is sitting on two sites. One is subject to this profit surplus plowback requirement, but then another site is not subject to that requirement. So I do have suspicion that is, even if they have engaged a professional auditor to conduct the auditing, so how are they to effectively distribute it among the sites, and the auditor would be able to know whether or not they comply with this particular condition? For the 20% low charge beds, I said previously that in future, in their audit report, the auditor could actually put down a footnote
to tell the readers how many free beds and low-charge beds there are? Well, I think either the Bureau or the Department will have to answer this question. That is, how can the auditor express his opinion about compliance? I've made another suggestion. If a private hospital has 2 sites, only one of which has this plowback condition, then in future, in the audit report, can we require the private hospital to differentiate between revenue and expenses for the 2 sites? That is, to differentiate between the 2 sites. Can we have a footnote from the auditor in future? Well, if the assumption is a rational one, I believe this can be done. Well, I think your question is rather complicated. Can you simplify your question? Because there are not professional accountants. I would like to ask whether the department or the bureau know what standards, criteria, or methods were adopted by the auditor for a private hospital with 2 sites. How to ensure the compliance of this profit surplus plowback requirement. Mr. Chairman, may I refer you to the example of LG6 in C of paragraph 3.12. That's page 34. That's rather complicated. 76.6% of the land were not covered by this profit surplus plowback requirement. Well, some audited figures were submitted to us, and the DH is now studying them. We have to study the accountancy details and legal details, and the process is still underway. Your second question, well, it's actually a suggestion. Well, please ask questions first before making suggestions. Well, in fact, my question has been answered. Let me make a suggestion. I hope that in future, in the audit report, there can be a footnote to differentiate between the 2 sites, such that the auditor could provide the footnote in the sample form or the template provided by the department. Well, the administration can answer this question or otherwise. Well, we'll try as far as possible, but specifically we do have difficulties. Any more follow-up questions? No. On Mr. Leung's question, may I follow up on paragraph 3.12? Now, please refer to paragraph 3.12, A, B, C. There is a major problem here. The grantee of the site and the hospital were different, except for C. So, what about your scope of review? How are you going to regulate the grantee when the grantee is different from the hospital? In particular, in terms of profit control is really difficult. Well, I think Mr. Leung's question is a fundamental one. How are you going to solve that problem? Do you understand what I'm saying? Many incidents had occurred in relation to the transfer of profits. Well, the grantee is under the regulation of the land grant. I agree that this is a problem, but from our viewpoint, after the site is granted to the grantee, then the grantee is the holder of the grant. For concrete implementation, we may have to regulate the hospital and supervise the hospital and inspect the hospital. But insofar as land is concerned, it is the grantee that matters. So you did not actually talk to the grantee, so where does the responsibility lie? Yes, for some hospitals, the grantee was not actually operating the hospital. In the process, we did notify the grantee. After receiving the financial details from the auditor, we would look at the grantee, the hospital, and investment items to see whether or not the grant conditions are met. As the chairman said, this is rather complicated. But apart from Hospital C, who actually employed the auditor? The grantee of the hospital. Well, please explain this. This is a fundamental issue under 3.12. Can you explain to us? In the auditing process, we also detected this problem. The land was granted to the grantee. But after so many years of involvement, we only saw in Hospital C that the operation of the hospital was amalgamated with the grantee. So in that case, there were less problems. But when the grantee was different from the hospital, then the DH or the regulating authority would have to determine which transactions were recognized and which not. And of course, that had to be verified by a professional accountant. In the course of verification, the DH or the regulator, as pointed out in paragraph 3.7, had to spell out what were allowed and what not. Well, in future, we have to look at this very carefully. In future, only without consent can the grantee hands over the operation or part of the operation of the hospital to another body. Oh, Yokman is not here. Alan, second round. Oh, Paul, you want to ask questions? You have raised your hand. We'll take a break after this part. Because after the break, Paul, you have to be the chairman. If you want to have some convenience, you can do so now. I'm afraid we can't finish part 3 before the break. Well, no time constraint here. Paul, we have the whole day here. Oh, members, you want to take a break? Can we go on for half an hour more? We take a break at 11:30? Because if we break here, we may have to ask questions afresh and it will become quite meaningless. I'll pass to Alan then. All right, Alan, Chairman, all along we're asking questions about the profit surplus plowback requirement. Well, that's paragraph 3.12. Now, the issue here is how to enforce the requirement. Well, just now we pointed out the difficulties. Now, Hospital C and Hospitals D have 2 sites each. Hospital C got Grant 3 and Grant 4, and then Hospital D got Grant 5 and Grant 6. Well, let me say something about Hospital C first. Just now, the Director of Lands pointed out that 76.6% of their land was under Grant 3, in which there's no profit surplus plowback agreement. Well, I got the impression just now, I don't know whether I'm correct. I'll give a chance to the witness to answer. For this profit surplus plowback requirement, if it is to be applied to Hospital C and D, then actually all along you did not face the issue that in the grant there's no such requirement. So be it the hospital authority or the DH, there's no justification for implementation. Am I correct? Well, I think that's the core issue. That's why paragraphs 2 and 3 are so important in terms of salient requirements. Can you answer Mr. Leung's question? Now, you said that if a grantee has 2 sites under 2 different sets of grant conditions, thus leading to implementation difficulties, I agree. So why didn't you do something? We would try our very best to tidy up the differences and clarify the differences. We did try to face them, but there are difficulties. Well, we have difficulties from day to day. The issue is to solve the difficulties, to resolve the difficulties. How are you going to face these difficulties? Perhaps we need to enhance enforcement on the part of the Department of Health, that is in its ability to audit. Well, it's not just an auditing issue. There is something to do with the land grant. You did not do something that you should have done. Well, Paul always asks this. Well, Mr. Leung, would you please repeat your question? Well, Chairman, the Secretary was actually trying to answer my question. Now, the question is like this. For this profit surplus plowback requirement, as far as we can see from the cases of hospitals C and D, I really cannot see how you can overcome the difficulty. Just now, Mr. Kenneth Leung suggested something. The Secretary already said that the suggestion was not that feasible. And in history, we cannot see what they had done to resolve the difficulty. So this so-called profit surplus plowback requirement, if it is to be applied to the audited hospital C and D, the requirement is tantamount to nothing because there is no objective system to cause the hospitals to enforce this profit surplus plowback requirement. Well, Chairman, in your question, you brought forth a point which I was about to ask. Well, just now the Director of Lands told us that she had sought legal advice on how to handle Hospital C and D. Can she tell us when she obtained the legal advice? Director? Well, can you move closer to the microphone? As far as I understand, recently in September, the Department of Health sought advice from us, and it's just recently that we offered our advice. So what's that advice? Our advice is, if there is this requirement for one site and no requirement for another site, then the proceeds, the profits and surplus should be proportionately distributed. Where's that legal opinion? It's in a document. Well, it's not that we don't trust you, but we would like to have access to that document so that members would understand the legal advice that you had offered. Well, you can write up another paper to tell us the legal advice. Well, Mr. Chairman, I'm not really asking for the document itself. Well, if there's a piece of legal advice, it's not that we would like to interfere with the work of their department. But she could not just tell us that this legal advice, we have the right to peruse papers. Well, if they're not going to give us the document itself, then the Director of Audit should read that document and pass the contents on to us. Well, that's a fundamental principle insofar as our operation is concerned. Well, I understand. Perhaps the Director can pass the legal advice to the Director of Audit as suggested by the Chairman, or give us a summary. But I think the most important point here is that they only obtained the legal advice in September. Before September, how did the enforcing department implement the requirement? If they actually implemented the requirement, they would have discovered the problems related to Hospital C and D, which were granted the sites under Grants 3 and 4 and Grants 5 and 6 respectively. If anybody does not agree with me, he or she can point it out. Director? Well, Mr. Chairman, we continuously follow up on this. At the end of 2010, we asked for the auditor's report on the requirement, and then gradually, from mid-2011 to early 2012, the hospitals gave us the auditor's return on the subject, and the Department of Health is looking into those reports. In the course of doing so, they have to clarify with the Lands Department the details of the land grants, and they also have to obtain further details from the grantees. Yes, there is complexity in the calculation, so we do need some time to resolve auditing details. That's why we try to obtain legal advice from the Lands Department. But in the course of in the process, we did ask the grantees for clarifications. Well, Mr. Leung was saying something about Hospital C, which is under 2 grants. One is LG3, the other one is LG4. LG4 does carry the 1981 plowback requirement. From 1981 till now, that is recently, it's only recently that you acted on the requirement. So what have you done in terms of law enforcement? May I refer you to Table 2. Table 2 in relation to the 2 salient requirements and the proceeds. Can you read Table 2? Can you give us some papers as to how you for so many years monitor them in terms of proceeds? Well, we'll give you papers. Mr. Chairman, if you read paragraph 3.12, you see that for Hospital C, LG4 spells out the grantee. Well, Mr. Chairman, you referred us to Table 2. Table 2 for LG2, LG6, and LG8. Therefore, hospitals B, D, and F. They are related organizations. Or there's no organization that served as the grantees. for notes 2 and 3 of table 2, you can see that, well, I'm talking about the parent organization. Hospital C's parent organization was originally the grantees of LGs 3 and 4.
According to the audit report, in 1981 and 1982, through an arrangement, the name of the grantee was changed. Did you monitor the process? Were you aware of the process, of the entire process? How does the change of name affect the two salient requirements? If you say that you have been following it, then can you give an account of your involvement in a chronological order by way of an information paper? Yes, we will supply it after the meeting. The impression I get is still the same. The Director for Health endeavored to explain that it was only in September that they sought legal advice through the Lands Department, and they have monitored. But I want something that is solid, not just hot air. If you can draw such a conclusion that you were aware that something was done, I think I need a bit more assistance from you. You said that it was only in September that legal advice was sought through the Lands Department. And I think you're taking your time. That may be my conclusion. If that is not the case, then supplied us with the information, say Hospital C with the change of names. Give us the information so we may draw a conclusion that reflects what you've said. Otherwise, there's only one conclusion we can draw, and that is one that shows that you haven't really done anything. Yes, we will supply detailed information. Alan, perhaps we pause here. Yes. Let's take a break of 10 minutes, and we will come back at 20 to 12. We come back. We'll resume at 11:40. I don't think we can finish this morning, and we will adjourn at 1:45 and come back at 2:30. Alan, do you have other questions? I don't mind. When we come back, Mr. Ng Leung Sing will ask questions.